Now, limbic system, I want you to learn something now more. You know, this is running. So I told you in the beginning that we will, in the first session, this will be walking and then gradually we'll build up. This is something which I want you to learn. Some of it is beyond 2B, slightly beyond 2B, but having said that, anatomy is important because now this is limbic system. Now, I'm not going to teach you limbic system in great detail, but I will teach you what you can see on imaging. Limbic system is emotional brain, and there are portions there which are interconnected. And you know, something in the hypothalamus which is connected to the hippocampus in the temporal lobe and things like that. Now, this is a beautiful diagram from StatDX, which tells you that limbic system anatomy can be, the concept is the 3 arches of limbic system. So this is the outermost arch, which is the cingulate gyrus. And if you see, it goes all the way, and here it ends in the uncus. So remember uncus. So this uncus is the medial most portion of the temporal lobe. Important point. So from here, what you have learned, that is a gyrus, uncus, that is a gray matter. Now here is hippocampus. Hippocampus has got various parts, and this is head of hippocampus, then is the body, etc. And then it turns around the corpus callosum, and this thing, which is indusium griseum, it is not visible on imaging. Don't worry unless you do a very high-tech MR. So don't worry about it. But the main action is here. If you see, this is the fornix. Fornix is a midline structure, and on imaging, particularly the coronal sequences, it is visible. You should have a concept about it, and that is why I'm teaching it. This is fornix. So we have got 2 fornix, and this is crus of fornix. And as we go superiorly, it is touching the splenium. Here, the 2 fornices, right and left, will be in communication through commissure of fornix, but here it will become a body of fornix. And then it will turn like this and ultimately turn into what we call column of fornix, which will end up into the mammillary bodies. Remember the mammillary bodies which are sitting in front of the midbrain. So here comes another concept, the concept of septum pellucidum. You know, septum pellucidum is the midline membrane in between the ventricles. So this diagram also tells you what happens. Septum pellucidum, from here till here is the septum pellucidum. Point to remember, septum pellucidum divides the frontal horn and body of lateral ventricles. More posteriorly, actually, there is no septum pellucidum. And in the midline, you will see the fornix. So these things we will see on imaging. So now this diagram also tells you the same thing, that this is the hippocampus, and then this is the crus, this is the other crus, and this is the commissure here, and then is the body, and then is the column, and then is the mammillary body. So, and superior to that, you can, stretch of imagination that the corpus callosum is sitting here, which is visible here. So this is the corpus callosum. From here to here is the septum pellucidum. Here there is no septum pellucidum. How will you see it on imaging? So this is fornix, and this is septum pellucidum. We are slightly anteriorly. Okay, I'll come back to the imaging, but this is the hippocampus, which is the medial most portion, not the medial most portion, but the medial portion of the temporal lobe. Okay. And I will go to actually a PAX case.
Doctor.
Can somebody tell me, any candidate with us? Can you see Radiant DICOM viewer?
No, we can just see the PowerPoint.
Okay.
And people are just commenting that they're not able to see your pointer clearly. I don't know if we can change it to something more visible.
Okay.
Yes, thank you.
Can you see the Radiant now or not?
Yeah, can do.
Okay. So here I don't think so I can change my pointer here. But the point is, first of all, orient yourself on this. So can you see my pointer on Radiant?
Yeah, I can see your mouse pointer.
Okay. So now you can see that this is the corpus callosum, and you can see that this is the mammillary body. And from here to here will be the septum pellucidum. This is midline. But if you see, this is the mammillary body, something is sitting here. So this has to be the fornix. Now, if we go here on this, and this is reference line so that you can orient yourself. Now we are just concentrate on the temporal lobes. Anteriorly, we can see that there is uh, this portion is the amygdala, and as I am going posteriorly, this is the temporal horn. So this is the hippocampus. This is the hippocampus. So from the hippocampus, the white matter will come out, which is the which will ultimately make the crust. And if I trace it backwards, actually, you can see that this, and just see where my mouse is, and you will see this is my mouse, and this is hippocampus, and it ends here, right? So these are the fimria, and I am tracing it backwards once again, and you can see it goes all the way here. Where are we? We are at the corpus callosum, and it goes and touches here. So this is the corpus callosum. Now we are going to come anteriorly. As we come anteriorly, the septum pellucidum arises. You see, I go back, there is no septum pellucidum. And as I'm coming anteriorly, the septum pellucidum is in front of us. So this is the septum pellucidum, and this is the body of the fornix. And now we are coming anteriorly. Look at this. This is the mammillary body here, right? And this is the body, and it has to go down. You see, it goes down like this. It goes down like this, and it goes down into the mammillary body. So this is the anterior pillar, and this is the anterior pillar. So you can beautifully trace it like this. Another thing which I want to show you, now on this sagittal, you can see that there is anterior commissure here, and there is lamina terminalis here. So if you can actually see it here very well, you can see this is head of caudate nucleus. This is the lentiform, and you can see this white matter and how it is going to the other side. So you see, this is in reference to this. So this is the anterior commissure, and you can see how it crosses the midline. So this is fascinating on a coronal sequence. This is a special sequence which we do for epilepsy, which is a T1 weighted sequence, but gives you anatomy. I'm not teaching you further anatomy of the limbic system, which is a huge subject, but we crack on. But now you have learned fornix. So can you please confirm that if you are seeing a diagram of the midbrain?
We can see that, but it's not full screen. It's just
Yes.
your, yeah.
Is it full screen now?
Yeah, just now.
Okay. Something to learn more about midbrain is that so this is the midbrain. In the midbrain, two nerves come out. Anteriorly, this is the third nerve, and posteriorly there is the fourth nerve, trochlear, which comes at a slightly inferior level. So this is the superior colliculus. Two words should be in your vocabulary. Now, if you see here, if you look carefully, basically this is the aqueduct. So from here till here is the tegmentum of the midbrain. From here till here, the posterior is the tectum or the quadrigeminal plate or the tectal plate. So this is the difference. The cerebral peduncle is this thing and this thing. This thing is the substantia nigra, and this is the red nucleus. And on imaging, you will see them, particularly on a gradient echo sequence, because there is what we call iron deposition there. So this is the fourth nerve which are coming out. And so this is a 7 Tesla MR. But having said that, anatomy is beautifully seen in a sec. This is the superior cerebral peduncle. But I just wanted to show you this, substantia nigra, which is because of iron deposition, it is black. So, but these things can be seen on a 1.5 Tesla also. You can see the mammillary bodies anteriorly. Same part of anatomy, which we have already learned. So this is ambient system, and the posterior cerebral artery also goes through the ambient system. So rest of this anatomy, I think we have so just a overview of this cerebellum. Midline is the vermis, and cerebellar hemisphere is right and left. Inferior-most portion is the tonsil. Now, this is the midline, and this is the vermis. Such a complex anatomy, if you want to go into details, and everything has got a name here. There are fissures, horizontal fissure, and superior fissure here. There are names here, nodulus, for example. I don't want you to particularly stretch yourself with these names, but one name I will like you to remember. Tonsil, of course, you have to remember. But there is another structure which is known as flocculus, which, if you see here, flocculus, this thing here, this should be in your vocabulary, because next session we will do a highly T2 weighted sequence through the CP angle. And this, if you don't know this, this projects into the CP angle system, and if you can confuse it with a mass. So you have to know this. Otherwise, all of these things, there is no need of remembering the names. Vermis, cerebral hemisphere, tonsil, these are the main things. If you want to remember something else, remember that this flocculus on a highly T2 weighted sequence can project into the CP angle system, and don't confuse it with a mass. So these I am skipping a bit of repetition because of the time factor. So the pituitary gland, we are going to revisit this next session. So I am going to skip it. Donna has already covered a bit of it. In the base of skull, we are going to revisit this. And now the final part is the skull and the meninges as far as I'm concerned. And then Saqib will take over the arteries and the veins. So we know the name of the bones. So this is the parietal bone, this is the frontal bone, the occipital bone, the temporal bone, the sphenoid bone. And this is the coronal suture, and this is the lambdoid suture. Here, one relevant point is that if you look at the sutures, this is the coronal suture, this is the sagittal suture. The junction of these is known as bregma. One thing is this parietal foramen. So what happens is that there can be emissary veins which pass through the skull, and these emissary veins can be uh, so they pass through it, and this foramen is a, so should I say, a normal structure. But sometimes this will become very large as a normal variant. Key thing is that they will be in the parietal bone at this part of anatomy, and they will be bilateral symmetrical or close to symmetrical. And this is a normal variant, which is an exam case. I'll show you an example. So the skull X-ray, I am going to skip it. Please open a atlas like Abraham Weir or something and go through it. Of course, it can come in the exam, so go through it. And but I'm going to skip in the session itself. Foramen magnum on a Townes view. This is an angled view known as Townes view. Is quite a favorite for the exam. This part of anatomy, we have already covered it. And this is the X-ray, which can come in the exam. We have already covered it. One pitfall, which is an exam pitfall, is this thing. Please remember that clivus is made up of two bones, the sphenoid bone and the occipital bone. So in the growing skeleton in a child, there will be a synchondrosis there. Don't call it a fracture. I've seen, young radiologists actually confusing it. Is there a fracture? No, this is not a fracture. It's a normal structure. So on an MR, this is it. We call it the spheno-occipital synchondrosis. And ultimately, it will just become a single bone in an adult. So, okay, this is the final part of it, which I want you to really concentrate on, because this is extremely important and extremely important for your concepts of examination. If you see this diagram, this is the skull, this is the outer table, this is the inner table. Within these two is the diploic space. So the diploic space has got fatty marrow, which will be high in signal intensity on T1 weighted sequence. Now let's go more deeper. Now deep to the, so first of all, superficial to that is easy. You know, this is scalp. We don't have to learn as radiologists more than that, that there is what we call, you see this thing here, which is overlying the skull, is known as Galea aponeurotica, or galeal aponeurosis, and there can be scalp hematomas actually sit under this. So many of the surgeons, they will use this word galeal hematoma. So that is just soft tissue, right? Now coming back to anatomy, if we go deep to it, is the dural venous sinus. So the dura has got two layers, inner and outer, and the outer layer is adherent to the periosteum of the bone, and this is the other layer. They split together, split away from each other to give space, or they form the superior sagittal sinus. This is a coronal sequence, right? And you can see that there are other veins. These are veins which are passing through the skull. Emissary vein is important, which is passing through the skull and going into the scalp. On the other hand, deeper to that are other layers. Now, there is an arachnoid, which goes with it, with the dura. So the subarachnoid space is in between this and the pia mater. Now, the pia mater is adherent, which is in this green color. It is adherent with the cortex. So subarachnoid space between this and this. Together, these two are known as leptomeninges. And this is the pachymeninges or the dura mater. in the exam, in the 2B exam, favorite for the examiners to show you cases of leptomeningeal and dural involvement and things like that. So arachnoid granulation, now these are the arachnoid granulations which also contain CSF, and sometimes they go into the bone and they will cause a bony lytic lesion. So you have to know that as a normal variant. So here you are, look carefully, look at the layers of this. This high signal is fatty signal in the diploic space. Superficial to that and deep to that is the outer table and the inner table. So, and then is the scalp. So then you can see that this thing here is without contrast. This is the superior sagittal sinus. With contrast, you can see flow there, and you can see a cortical vein there. So the same thing here, where you can see outer table black line, diploic space white, another black line inner table. Because this is midline, you can see the superior sagittal sinus. So this is what the subgaleal hematoma. So you must have reported so many of these. So by definition, this is underneath the galea. Fox anatomy, we know, and I think Saqib is going to cover it. CT anatomy, because I'm going to cover base of skull next time, we will revisit this. Now, this is a case, because of time factor, I'm not going to go into a viva mode, but in the last 5 minutes, I'm going to show you a few viva films. So this is a viva case. And if you see here, there are two foramen, right and left. And the key thing is, look at the anatomy. So this was the parietal. So these are the parietal foramen, as I pointed out. So you see this thing? So these are normal variants. Sometimes they can become so big. So this is parietal foramen. And in your book, in Chapman, there are two differential diagnoses. In skull vault lucency without sclerotic edge. This is one. And second will be skull vault lucency with sclerotic edge. And the differential diagnosis is different. And you see here, normal. Parietal foramen is there. If you look carefully, look at the margin, and there is no sclerosis. So this is from Chapman. So I just wanted to introduce to you this aspect for your 2B exam. Another case, and this is different. If you see here, you can see lucency, 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 lucency. And these are all overlapped here. So what is happening? And this is arachnoid granulations which have gone into the bone. And anatomy tells you what is happening. It is sitting next to the transverse sinus. And look how it has gone into the bone. Look at this MR, and you can see a bit of CSF inside. So nothing to worry about. These are arachnoid granulations of no concern. This is a case report from literature, and they also did a bone scan. There was no need of a bone scan, by the way, because even on a CT, it was black and white diagnosis, arachnoid granulation. And this is from your Chapman, skull vault lucency with sclerotic edge. Look here, arachnoid granulation. Look at this venous lake. And venous lake, look at this diagram. What happens? That within the diploic space, sometimes the veins are prominent, and it will give you a bit of lucency, which is one of the differential for skull vault lucency with sclerotic edge. Now, as the vessels they pass into the brain, there is perivascular space around it, and so sometimes there are enlarged perivascular spaces, And these perivascular spaces should be, you should know that this is normal and of no concern. Look at this case. And I've seen so many people at times reporting these kinds of cases. This patient presented to the A&E with stroke-like symptoms, and it was reported that maybe there is lacunar stroke, but there is no lacunar stroke. This is a normal variant of enlarged perivascular spaces. And on an MR, you can also see the same thing. So the anatomy is that as this is the M1 segment of MCA, as ventriculostriate branches, they go in, the enlarged periventricular spaces are there. So this is also known as Virchow-Robin spaces. And here you are, Virchow-Robin spaces. Classical locations are basal ganglia and white matter, as well as the midbrain. We will revisit all of these things, but today I just wanted you to sort of introduce this to you. Look at this case. This is dural metastasis, classical exam to be fair, classical. And here, what is happening? What is happening is that if you see here, this is post-contrast, this is pre-contrast. There is a mass here. When we give contrast, look at the dura, it is all enhancing. This mass is passing through the diploic space and coming out on the other side. So a novice will initially report it as a meningioma because this is a dural tail sign and things like that, without realizing that it is infiltrating, it is going through the diploic, coming out. This was a metastasis. By the way, there is a concept of malignant meningiomas and infiltrative meningiomas, but this is only 25 years old, and this was a metastasis from rhabdomyosarcoma. Look at this case. Patient presented with fever, and contrast is given, and you can see that there is enhancement of the pia mater. So the leptomeninges are enhancing. And look at the vessel. The vessels are in the subarachnoid space. Key thing is that please remember normal anatomy, that the vessels, they are in the subarachnoid space. So the pia mater, what will it do? It will dip into the sulci. So you can see it is adherent with the brain. So this is a unique case where the leptomeningeal enhancement, pia matter is enhancing, and the vessels can be separately seen in the subarachnoid space. So this is the differential diagnosis from your book, meningeal enhancement. And it can be, dura arachnoid, pachymeninges, and it can be leptomeninges, pia arachnoid. And these are favorite, absolutely favorite for the exam. And things like infections, carcinomatosis, and things like sarcoidosis are favorite for these. So this is a case of TB, and you can see this leptomeningeal enhancement causing hydrocephalus. And this is an MR of leptomeningeal carcinomatosis. Again, classical exam case. Examiner is going to show you a flare sequence on which CSF is black, but in this case, you can see the sulci, they are high signal. And when we give contrast, you can see that there is enhancement and enhancement. So this was leptomeningeal carcinomatosis. And the concept of perivascular spaces, sometimes infections or other inflammatory processes can go through them into the parenchyma. This is an example. I'm just showing you the example, but not teaching in detail. This was sarcoidosis, and this is in your Chapman, enhancing lesions in perivascular spaces. So we will learn this later on. Final case of the day is an anatomy thing. If you look carefully, this is a cis sagittal sequence. This patient has got fever and headache. And if you look carefully, you can see that this is the cerebral peduncle. Anterior to that, has to be the, this is the suprasellar cistern and partly the interpeduncular cistern. And if you look carefully, look at the third ventricle, and you will appreciate that here the infundibular recesses of third ventricle and the chiasmatic recess, it is quite prominent. So this patient has got hydrocephalus. So what has happened, if you see this T1 weighted sequence, look here, on this T1, there is no CSF. When we give contrast, everything is enhancing. So whole of the subarachnoid space is actually replaced by inflammatory tissue, a phlegmon, which is of course causing obstruction to the flow of the CSF. And that is why there is hydrocephalus and it is enhancing. And in your, so if you see here, there is hydrocephalus also as the temporal horns are dilated. And in your old Chapman, the previous edition, I think this was beautifully given that subarachnoid space, enhancement of subarachnoid space can happen. So this is what is referred to. Just to explain, I say that as if the river is on fire, there is petrol inside the river and everything is on fire. So the subarachnoid space is on fire. So I think I will defer the quiz and maybe give it to you next time. And for the time being, I think we are running late. So over to Saqib.
Okay, just want to make sure, Dr. Khan, can you hear me well?
I can hear you.
Perfect, excellent. Right, so we'll start off by just having a very brief reflection over the vascular territories. Hopefully this is something that's familiar to everyone. It's something that's normally covered during med school and early and during a lot of neurology rotations during med school as well. Basic concept is that in the supratemporal brain, there's 3 vascular territories. The anterior cerebral artery, which tends to be slightly along the midline, and tends to cover pretty much the frontal parietal lobes. And then the MCA segment, which tends to have the largest volume and covers predominantly the large bulk of the cortex of the frontal parietal lobes and the superior half of the temporal lobe. And then finally, the posterior cerebral artery, which covers the occipital lobe primarily, and also a good portion of the lower half of the temporal lobe as well. And then when we go into further deeper territories and look further through multiple cross-section slices, we can see that there is a slightly more complicated pattern. So, for example, the medial temporal lobe segments, which we've covered briefly in Dr. Khan and Donna's talks, this is actually covered by an artery called the anterior choroidal artery, which arises directly from the internal carotid arteries. And we'll come across a few examples of why that's significant. Other structures to be aware of is where we talk about the basal ganglia. They have a slightly split supply, and it's important, especially because we are working a lot more with stroke patients, and we're now in the day and age where thrombectomy is rapidly advancing and becoming a viable treatment strategy for these acute strokes. So having an appreciation of these vascular territories and cerebral angiograms is paramount, and hopefully you're getting a lot more experience of these as well as a result. So the basal ganglia territories, as you can see, to orientate yourselves, this is the frontal horn of the lateral ventricle, third ventricle, and these are essentially the basal ganglia segments. As you can see, the head of the caudate nucleus territory is predominantly supplied by the medial lenticulostriate arteries, and that's actually branches of the ACA. The putamen, lentiform nucleus, and globus pallidus regions, they are from the lateral lenticular striates, as well as the body of the caudate, caudate as well. And these are from the MCA territory. And then finally, you can see a very narrow change over here. You can see the same pink reference at the medial temporal lobes, and this was from that same anterior caudate choroidal artery as well. And specifically, this region over here is actually the posterior limb of the internal capsule. So that's something important to realize, which is why you can have multiple lacunar infarcts in different territories. The anterior limb and the posterior limb are supplied by 2 different vascular territories. So an important concept so you can appreciate is this whole concept of border zones or watershed areas, which we do see occasionally in the context of infarcts. which don't really conform to a specific vascular territory. And the whole concept and logic behind these is because they're essentially at that watershed zone between two vascular territories, there is, in theory, a reduced vascular supply there. So if you have a hypertensive state or someone who has peri-arrest or acute cardiac arrest, they can have reduced supply to these specific areas, and these may manifest as infarcts. Quite a common region is this internal border zone. And this is an interesting concept, and I'll tell you exactly why, because we tend to see these quite frequently, and they tend to be infarcts in the white matter tracts, specifically in areas called the centrum semiovale. And we'll go through exactly why you see that. We'll go through all these anatomical diagrams in a second, but I talked briefly about these lenticular striate arteries which cover the basal ganglia. The area which I marked, which is that border zone, is pretty much in this level here. As you can see, these small terminal branches from the lateral lenticular striae and also the kind of deep infiltrating cortical branches from the M3 segment, or M4 segment actually, the terminal branches essentially cover this long segment of white matter tract. So if you imagine a state of hypovolemia, or if there's an acute internal carotid occlusion or chronic occlusion and a low output state, you're going to get quite significant compromise of flow into the middle cerebral artery. As a result, the one segment which is very vulnerable is this segment over here, which is why we quite frequently see infarcts. They do not really manifest quite clearly on CT initially, but MRI and diffusion weighted imaging tend to light up these segments quite nicely. So it's something to be mindful of. That's the logical reason why those things happen. So moving on, we'll talk about the internal carotid artery to start with. So there's two schools of thought how to describe them. Now, for the anatomy exam, there was a long debate about how much do we need to know about describing each segment. The answer is you don't. You don't need to specifically, if they label an artery and it conforms to the internal carotid artery, you don't need to focus on the numbered segment or the named segment. You just call it the internal carotid artery on the side. It's more for when you're describing your day-to-day practice, just for guiding neurologists or neurosurgeons to be quite precise in your descriptions for aneurysms or occlusions or dissections. You can then talk about the parts. But very briefly, we'll talk about them. So there's four parts, if you want to say them. So below the skull is the cervical area. As the internal carotid artery pierces through the temporal bone in the petrous segment, it's called the petrous segment. As it then enters the cavernous sinus, and just above the cavernous sinus, it's namely called the cavernous part. And then you have the carotid genu or siphon, and then you have the supraclinoid segment as well. Now, alternatively, which I think people tend to adopt more commonly, is the numbered segments as well. And I think this is what the neurosurgeons and neurovascular interventionists tend to use a lot more frequently to describe pathology relating to a specific segment of it as well. It's worth reading in your own time. It's not necessarily relevant for the purpose of the anatomy exam. Now, an important concept, I know we've already sort of covered how the internal carotid artery does traverse through the cavernous sinus, but we never see that many sagittal sequences to show exactly the route that it takes. And the reason you can see the carotid artery in multiple slices in this very strange orientation is because it has multiple turns within the cavernous sinus itself. So this is just so you can appreciate the orientation. Now, the other reason is just slightly some pathology related as well. It's quite a common exams type scenario, clinical scenario in the 2A exam, where they kind of give a very classic history of a patient, a young patient who's had a form of head trauma, no initial injuries, represents a few weeks down the line with visual loss, pulsatile tinnitus, or proptosis. And then the concept is that they've injured and caused a carotocavernous fistula. And this is essentially representing how that happens. You can get a small tear, a lot of high flow pressure within the cavernous sinus causes quite significant congestion of the ophthalmic vein. But we're not going to dwell on that too much. So again, a familiar diagram, hopefully. This has been drilled into us since med school. So this is the classic appearance of the circle of Willis, and the named the arteries are the anterior communicating, the anterior cerebral, middle cerebral, and posterior cerebral, and they're connected by these communicating arteries to complete the ring, the PCOM and the ACOM. Now, the reason these are significant in a clinical context, if you do have an occlusion, for example, in the internal carotid artery, potentially you have got preserved circulation supplying the brain, maybe not fast flow or rapid flow, but enough circulation for a period of time to try and prevent any significant infarcts. And that's the whole logic behind why the circle of Willis is an important safeguard in cerebral anatomy. So this is obviously a schematic diagram, a slightly more representative image of how it looks like. This is just a 3D reconstruction of showing you roughly the orientation. As you can see here, this is the basilar artery coming in, and it splits into the posterior cerebral arteries. And then you can just about make out these posterior communicating arteries which arch forward. And these are the bifurcations. So you have the anterior cerebral and then the middle cerebral coming on either end. And you can see the ACOM centrally. And we'll go through a few imaging investigations for this as well. So very briefly, just to also just put it into context, this is the same image that we've just shown you in a second ago, but the relevant image in the MRI world. We'll go through a few examples. So I think what is challenging when it comes to cerebrovascular anatomy is that you have branches coming out everywhere. And sometimes it gets a bit confusing and daunting trying to figure out what is what. The truth is, in the anatomy exam, you only really need to know the core central arteries. These peripheral branches aren't readily identifiable. And in a neurovascular, if you're an interventionist, sure, it makes 100% sense to really revise every single one of these. But from a first year anatomy point of view, it's the central vessels we're going to concentrate more on. So very quickly, I'll go through the anterior cerebral artery. Essentially, the branches on the anterior cerebral artery are the only ones that tend to be in the midline and can potentially be seen in one or two slices. So they're probably, if anything, the most readily identifiable. In the middle cerebral and the posterior cerebral, they tend to diverge into multiple planes. So they're very difficult to trace and accurately determine which branch is which. And that's why I'll go through a few of these branches of the anterior cerebral artery because they have come up in the exam before. This is the anterior cerebral artery, and you can notice that it courses in the midline and within the interhemispheric fissure. And as you can see, it loops and arches around the corpus callosum and stays quite in close proximity, and again, it has multiple branches as well. The branches to know about, the very first one that arises quite close to where you see the anterior communicating artery is the orbitofrontal. The next branch up just below the level of the rostrum would be the frontopolar. And then the final two branches is where you get the bifurcation just above the head of the corpus callosum. And then the one that traverses through the cingulate gyrus that they talked about before is the callosal marginal. And then the one that pretty much stays quite close to the corpus callosum all the way through is the pericallosal artery. These are the ones which I would focus on when in the anterior cerebral artery territory, because like I said, in a nice sagittal sequence on MRI or CT, you can potentially see these branches quite easily because they stay within that one sagittal slice. And again, I'll go through some examples shortly as well. Middle cerebral artery, we've briefly come across this so far already. Quite straightforward anatomy and quite readily identifiable. People are quite easily orientated to the presence of the insular fissure and the insular lobe. So you can use that as a rough guide of where the middle cerebral artery would be. Again, each of these cerebral arteries do have their own segments. I don't think it's necessarily relevant for the anatomy exam, but for day-to-day learning, it's worth investing some time to try and figure out the segments as well. For example, if you were to report in a CT angiogram that someone's got an occlusion of the M1 MCA, that rings alarm bells to everyone in the neurology world, because that means it's a very proximal occlusion. So that's why that kind of phrasing and wording is important. But from an anatomy exam point of view, I think it's quite straightforward to say middle cerebral artery. Main thing is it traverses, has a horizontal segment, then a vertical segment within the fissure, and then has multiple large branches which go along the cortex as well. They tend to go towards the parietal and frontal lobes, and also inferiorly around the temporal lobe segments as well. Finally, in the posterior circulation, the most notable branches are the posterior cerebral artery, which tend to be the terminal branches of the basilar. The basilar is a very easily identifiable one because you can use the clivus as a nice sagittal landmark in most cases. Now, it's really crucial that you understand the anatomy and the vessels involved in the posterior circulation. Again, because they're quite small and narrow caliber, they can be potentially difficult to view on a lot of cross-sectional images. But when you have infarcts, because they're quite small caliber vessels, they are prone to causing small infarcts in the posterior territories. Common arteries to know about are the posterior inferior cerebellar artery, which arises actually directly from the vertebral artery. Next one you have is the inferior anterior cerebellar artery, which arises as the first branch of the basilar. Multiple small perforating arteries, which are pontine branches, and just before the final bifurcation into the PCA, you have this superior cerebellar artery as well. And we'll try to look for these on the subsequent angiograms we have. This essentially just tries to demonstrate some of the branches which can be potentially identifiable in the posterior circulation, the PCA territory. To be honest, the only ones I've really seen quite easily are these two terminal branches, the parieto-occipital, mainly because you can see it running through the parieto-occipital sulcus, which is quite easily seen on the sagittal brain MR or CT. And finally, the one which hugs pretty much the tentorium is the calcarine branch, which we will try to visualize. The rest of them quite difficult to see, to be honest. We've already sort of covered this concept already, but this just reinforces the whole arrangement and orientation of these small vessels arising from the basilar and vertebral arteries. I won't go too much because we've already covered this briefly as well. So let's go through a run through on a CT angiogram and try to identify some of these vessels by tracking them. So we'll start off roughly at the level of the base of the skull, just to orientate yourselves. This is the internal carotid arteries, the cervical portions. As I'm scrolling through, we're going north, superior towards the skull, towards the top of this cranium. And as you can see, it goes into the carotid canal in the petrous temporal bone. And then you can see this very characteristic horizontal segment. This then has multiple loops and angles. And this is essentially where, as it turns upward just above the foramen lacerum, it joins the cavernous sinus. So this is the cavernous segment of the internal carotid artery. And this is why I said it can be sometimes confusing, because as you can see two separate segments of the internal carotid artery on this one slice. So just be aware of this slightly tortuous anatomy, which is completely normal and expected. As it goes through and you see this tortuosity, at some point you will see that it curves laterally, and that tends to demarcate where it becomes the middle cerebral artery. And as we track this vessel, you can see that it tracks between the fissure, and that's how you can readily identify this as the middle cerebral artery. Alternatively, if we go just inferior a few slices, you've got a couple of branches which diverge medially, and these are the anterior cerebral arteries, and they tend to traverse in the midline within the anterior cerebral fissure, as I've described. Finally, very briefly, I'll go through the basilar segment. So going down to the skull base again, you can see that there's typically two vertebral arteries. It is fairly normal to have one smaller than the other. Sometimes they're very small. Clinically, it makes a difference because if you have a pathology in one dominant vertebral artery, it can cause quite a large infarct in posterior circulation. But typically, you tend to have two, one's slightly larger than the other. As they merge together, it forms the basilar at the level of the clivus. And then you can see these multiple small branches which are providing pontine supply. And then you can see one larger branch, which is the superior cerebellar. And as I come to the terminal segments, you can see the posterior cerebral arteries as well. And these are important structures you can just about make up on this angiogram, that you can see part of the midbrain at this section over here. And this runs in the ambient system. And that's an important anatomical landmark for you to remember. So going through just a couple of different angles, you can hopefully, like I said, so if you get the opportunity to review these CT angiograms in your day-to-day practice and trace these vessels, it will become a lot more apparent. If you look for them, eventually you commit it to memory. This is just a very quick view of the internal carotid artery as it traverses through the petrous temporal bone and also through the cavernous sinus. So this is that very characteristic bend that you see as well. Other segments you can see over here, if you were to try to guess exactly which vessel this is, you can see that it's traversing posteriorly, and you can see it's having a branching pattern as well. And roughly you can see that this is almost going towards this parieto-occipital suture. So that will be the parieto-occipital branch. Going through another segment, again, you can see just at the level of the clivus, you can see the basilar artery coming through, and we are midline, and the way we know that, you can just about see part of the corpus callosum centrally as well. So we know that we're very midline in the brain. And these vessels which traverse around there are part of the anterior cerebral artery. Namely, especially, you can see these small branches. Remember that I said the first one was this frontal orbital, next one's this frontal polar, and then you can see this bifurcation. So the one that traverses above over here, that's the callosum marginal, and the one that carries on pretty much hugging around the corpus callosum is the pericallosal. Finally, on the coronal image, you can see these carotid bifurcation and basilar bifurcations quite nicely. And here you can see again the basilar centrally, big posterior cerebral arteries at the top, and then these smaller superior cerebellar arteries just below that as well. Multiple branches of the MCA territory, but again, these aren't specifically named branches. If they attack, it's very unlikely you're going to have an arrow to these, because it's not really one significant structure you can identify. You tend to get the arrows more centrally towards this main stem of the vessel. Let's go through a couple of MRI sequences, and this really is just to help you appreciate the 3D orientation of these vessels in the brain. So as we can see over here, I'll go to a more slightly oblique. We can see the internal carotid arteries with that tortuous course to them. And you can see centrally they converge to form the anterior cerebral arteries. And then you can also see this carotid bifurcation as well. So medially, it becomes the anterior cerebral, and then laterally, it becomes the middle cerebral. So it's very common to have an arrow here, or an arrow here, or an arrow here. So a very readily identifiable structure. As we can go towards a slightly different projection, I hope you can appreciate the orientation. This is the internal carotid artery we just spoke about, and this is the basilar artery at the back, and the posterior cerebrals having a very posterior course backwards. All these multiple branches are all related to the MCA. Similarly, if you were to have, it's very common for you to receive questions in these kind of projections. Important thing for you to try and understand is try to orientate yourself. So, and I'll come through a couple of issues that I had when I was trying to study for this as well, because the basilar bifurcation and the carotid bifurcation in certain planes look very similar. So it's important for you to try to figure out a landmark or some kind of feature which helps you discriminate which is which. Once you can identify that, you can work out what's posterior and anterior, and then fill in the gaps. This is a very classical feature of the basilar artery bifurcating into the posterior cerebrals, and the very chunky internal carotid arteries bifurcating into the middle, and the anterior cerebral tracking in the midline. So fluoroscopy, this is again a bit more challenging because most fluoroscopic images people don't routinely come across, so we'll go through a few examples. This is an internal carotid angiogram, and I hope you can appreciate a couple of things here. So how do we know that this is the internal carotid? Sometimes people have a bit of trouble understanding and trying to discriminate these bends and curves, which belongs to the internal carotid and which one of them belongs to the vertebral. And we'll come through a few comparative images so you can get a better appreciation of that as well. But this is an internal carotid angiogram, and you can see medially it becomes the anterior cerebral, laterally it becomes the middle cerebral. So you can just about make up some bony landmarks. You can see the nasal bone and cavities here, orbit here, and an orbit there. And you can see that this is very midline and it's not crossing over to the other side. And that's classic of the ACA arteries as well. And over here, you can see the middle cerebral. You can see part of the calvarium skull vault. In the exam, hopefully you have a bit of a better quality image. It may not project very well on your imaging screens at the moment, but normally you can just about make up on the DSA where the bony landmarks are, and it gives you an idea of which direction things are going. This is another slightly more oblique angulation of the exact same structures. Internal carotid T coming through, and then you can see medially it becomes the anterior cerebral, laterally it bifurcates, and these very large branches of the middle cerebral artery. This is a lateral view of the internal carotids, and just notice the rough difference. As you can see, all these vessels predominantly belonging to the middle cerebral artery are just going through multiple territories. This is just a very classic view, and I'll try and this is one that people get confused about, how to differentiate this from the PCA territory, and we'll come to an example in a second. This is the basilar vertebral angiogram. So contrast is given through the vertebral artery over here. It's essentially caused some reflux into the contralateral vertebral artery, but predominantly a lot of it's gone through. And this is when Dr. Khan mentioned the Towns view, so you can get a very good angulation of this as well. You see the basilar over here bifurcates into the two PCA branches, and these go toward the occipital lobes. And then you can just about see over here these prominent branches over here. These are the superior cerebellar arteries. If we now project to a lateral view, this is the appearance of the vertebral artery. And as you can see, with the posterior cerebral artery and circulation, everything goes posterior. You can just about see the back of the skull bolt over here, and you can just about see part of the skull base at this level over here, just to help you orientate yourself. So how do we differentiate between the carotid and the basilar bifurcation? So important things to try and to orientate yourself with is the midline crossing. The anterior circulation, the kind of internal carotid arteries, will not cross the midline unless it's an anatomical variant, but they wouldn't obviously show you that in the exam. If it crosses the midline, you're more likely in basilar and vertebral territory. Notice that the branches, so if I go back to a couple of examples, if I go to the internal cerebral artery, you've got no proximal branches. The first branch is the ophthalmic artery, which tends to happen at the level of this genu. If you see any branches below that level, it's abnormal. It's not meant to happen in the internal carotid. It's more likely to be the basilar. So if I now show you the basilar artery, as you can see over here, look at all these turns and curves. Multiple branches are coming off proximally. That's another clue to help you. And finally, bony landmarks can help. Just if you can see part of the calvarium, which might help you orientate what's posterior and what's anterior. So again, this is just a side-to-side comparison of what they both look like and how to discriminate against them. As you can see, the internal carotid over here, anterior cerebral artery, staying in the midline, not crossing over. On the other hand, look at the basilar artery splitting into the two posterior cerebrals. They're crossing over to both sides. Okay. Secondly, you can see that there are multiple branches coming off to the side proximally. Not a great image because I put the bone windows on, but there weren't that many. You couldn't see any branches in the proximal territories here. And finally, on a lateral view, again, a side-to-side comparison, just so you can fully appreciate the different pattern of spread of these vessels. Internal carotid artery, nothing proximally. You can see the ophthalmic artery over here and the anterior choroidal here, but those are the only two branches, and they're quite close to the bifurcation already. In the posterior circulation, the vertebral artery has multiple branches given off over here, the spinal arteries as well as the inferior cerebellar arteries as well. And then also you can appreciate that this tends to have a unidirectional posterior projection, whereas the middle cerebral artery converges in all sides. So again, you do get a lot of these 3D images. Very important, try to orientate yourself, try to figure out what's what. And the way to do that is symmetry is really important. All three of these kind of T-looking bifurcations, any one of them can be confused with the basilar or the internal carotids. So try to figure out one or two key features which will help you discriminate. For me, if you look over here, you can see this very classical bifurcation. Just before the bifurcation, you can see these superior cerebellar arteries. So any day of the week, I will always say that this is the basilar or posterior circulation, which by default means that these are the two internal carotid arteries. So let's move on to venous anatomy. I will essentially cover multiple segments of this. So we'll focus on the sinuses, the deep veins, and the superficial veins in turn. Now, this has become quite important to appreciate recently, especially with what's going around in the media and this whole big factor involving the vaccine and venous sinus thrombosis. So all of a sudden, we're seeing multiple scans, like triple or quadruple the number of scans we're normally used to. But it's also really important to have an appreciation of what you're looking for and how to look for them, and appreciating that anatomical detail so you know how to find them as well. So I'm hoping that you get an opportunity as a result of this media hype, that you might get an opportunity to report more of these scans. So the vascular territories, in a very similar concept to the arteries, is very different for the venous territories. I'm not going to spend too much time on them, but typically when you have these venous infarcts, they tend to be slightly more bilateral as opposed to unilateral. And the cardinal feature is that they don't conform to a specific arterial territory, which is when you start thinking about a venous infarct instead, as well as with other features as well. I'll go through the important veins to know about, but as you can see, if you radiology assistant has some excellent graphics which show these cerebral territories in the veins. I'd recommend you have a chance to have a look at it in your own time as well. So, dural sinuses, multiple sinuses to identify. They all are quite continuous, and I'm hoping you're quite familiar, so I'm not going to dwell too much time in them. I'll go through the superior, it's meant to be superior sagittal sinus, inferior, straight, transverse, and sigmoid. Two other sinuses which aren't as easily seen, but I'll try to go through them so you can have an appreciation of them, are the cavernous and the petrosal sinuses. Dr. Khan already went through how these sinuses are formed with in between layers of the dura. The rough orientation, and is quite easily seen and easily identified by most people, is this very large superior sagittal sinus, which arches posteriorly, draining a lot of the cortical veins, and then it essentially almost bifurcates, you can say, into these bilateral transverse sinuses, and then has this looped course with this sigmoid sinus, and this goes into the internal jugular. Other sinuses are this characteristic straight sinus, which Dr. Khan briefly spoke about as well. Just to give you an appreciation of how these sit in a 3D orientation, you can see the cavernous sinuses and the petrosal sinus coming in through here as they drain directly into the sigmoid or the transversal sinuses laterally. And you can see in the midline, you see this convergence or confluence of sinuses where all fall from the superior sagittal, inferior sagittal and straight, and the transverse sinuses all converge. We've gone through this whole concept of how the cavernous sinus has its appearance, so I'm not going to spend too much time on that. When it comes to deep veins, again, Dr. Khan's kindly already spoken about these, so the internal cerebral veins, the basal vein of Rosenthal, which is an important one, and the vein of Galen are the major ones that you need to be concerned about. And we've gone through this graphic already, and you can see that the internal cerebral veins are central within, just on either side of this septum pellucidum, and normally at the floor of the ventricles. And these are joined by these lateral orientated basal veins of Rosenthal. As these join, they become the vein of Galen. As the vein of Galen joins the inferior sagittal sinus, it becomes the straight sinus, which has an inferior course and oblique course to join the superior sagittal sinus. So it's important to understand that relationship. This again is a graphic which demonstrates the orientation of these internal cerebral veins. There are multiple smaller veins as well, but they're not really identifiable on most cross-sectional images, so I'm not really going to dwell too much into them. Basal vein of Rosenthal, important structure because it's something which accompanies the trajectory of the PCA arteries, and it runs along the ambient cistern and then converges centrally posteriorly. So this is just viewing that same structure looking upwards from the base of the skull. Superficial veins. Three main veins, or two if anything to be honest, are the ones to identify. The vein of Trollard, also known as the superior anastomotic vein, the vein of Lab, which is inferior anastomotic, and the superficial medial cerebral vein. Not as easily seen, but something which I'll show you and you can hopefully identify it. And this is how they're projected, and essentially because they are superficial, they're going to be lining the cortex. These are very important anastomotic veins. In the theory behind it is, if you have an occlusion or some kind of obstruction in the superior sagittal sinus, there is a potential way for venous drainage to still carry on. So this is the vein of Trollard. There are multiple large cortical veins sometimes. The vein of Trollard tends to be the largest one, and you don't necessarily need to see it on both sides. You normally tend to get a dominant vein on one side. Same thing with the vein of Lab as well, and you tend to see some form of a connection between the two, and they're the ones that are classically seen on anatomy exams. Important thing is that this has a very superficial orientation just below the skull vault around the cortex, and tends to be in the coronal plane. And then the vein of Lab drains directly into the transverse sinus. This superficial middle cerebral vein, again, not easily seen, but if you have a very good angiogram, you can see this vein which sends contrast anteriorly along the temporal lobe. And we've got a couple of examples of this. So let's go through a few images so you can try to orientate yourself with these. So Easiest one to identify is this superior sagittal sinus, which we've already spoken about. Straight sinus coming across here, and then you can see the vein of Galen with these internal paired cerebral veins. Okay, you can just about see the basal vein of Rosenthal coming in over here. Just a very quick question, because just to see if you can understand it, there's one vein that's coming across over here. If you want to type in your answers, if someone can answer, what do you think this vein is? Excellent, perfect. Yes, that's exactly right. It's the vein of Lab. The reason I've mentioned this over here is because these MR or these 3D reconstructions can be slightly tricky, because it's difficult to sometimes orientate yourself. Is this part of the deep venous circulation? Is this part of the superficial, or any of the kind of venous sinuses? And the way to try to counteract that is understanding that normal anatomy. If I know for a fact...
Excuse me, Saqib, your PowerPoint is not visible to us.
Oh, 1 second. Sorry, just bear with me. Let me see if I can fix it. Is that okay?
Yeah, it's fine now. Please continue.
That's fine. So the reason I mentioned this one is just what can you do to figure out what this vein is? So the important one is to try to figure out structures which you can readily identify and trace the track. If you can understand the route or the trajectory those vessels take, by the process of elimination, you can figure something out. So if I know for a fact that this is a superior sagittal sinus and a straight sinus, I know that these are all connected to these deep cerebral veins. So essentially, this one is something that sticks out like a sore thumb. I can roughly see that it is continuous with the transverse sinus, and that tries to hopefully, if in that process you can try to figure out any vascular structure which attaches to the transverse sinus. The only one that you can think of would be the vein of Lab. That's going to be prominent or easily seen. And also by the process of elimination, you know for a fact that this doesn't really conform to any of the other cerebral veins that you come across, or the deep cerebral veins that you come across. That's how to try to approach these kind of structures. So I'll go through a very quick 3D orientation of an MRI, just so you can try to appreciate how these vascular structures are orientated. So as you can see, again, the superior sagittal sinus, and branching into two transverse sinuses, sigmoid sinus, and then these essentially become the jugular. So as I go slightly more lateral, you can see roughly how this conformation changes. This is that vein of Lab that I was talking about. Again, because everything is almost merged into one, it's difficult to try and figure out where this starts and ends. But have a look to see where this ends, and that will hopefully guide you exactly what you're looking at. You can't really see a prominent trollard vein, and that's why it's important to recognize that it's not always there or not always that visible. You can see the straight sinus over here, and then the vein of Galen, and you can just about see these paired internal cerebral artery veins as well. As we go more laterally and slightly more anterior oblique, again, paired internal cerebral veins, vein of Galen coming up over here. The basal veins would normally have this kind of orientation. They're not that easily seen on this view, but that doesn't matter. It just means that it may not have been the greatest quality MRV. Goes into a straight sinus posteriorly and forms this confluence, and then you can see that it has that sigmoid shape straight into the jugular. Okay, there are multiple unnamed superficial cortical veins. It would be extremely cruel of an examiner to ask you what these are. I'm sure they have names. If you're not a neurointerventionist, I don't think it really matters for the anatomy exam. The only ones to really focus on, if you see a very prominent trollard vein which comes across, or the usual vein of Lab, which you can see is a dominant one over here. So when you see these MR venograms, hopefully you see a lot more of them. Try to trace all these paths and all these venous drainage pathways, and it'll make a bit more sense to you as well. Similarly, we'll go through a few questions. What I might do is just try to figure out a way that I can see the screen. I'll do it like this, actually.
What do you want to show? Because right now we are not able to see anything.
Yeah, what I'm trying to do, Dr. Khan, is the way you did it. So just to show those questions, but I want to try and see if I can see the chat as well somehow. So I'm struggling with.
You want me to sort of talk
Yeah,
through?
you just read out the answers roughly, if that's okay. Yeah, perfect. 1 second, let me restart my presentation. So this is an interactive part of it. So rather than going through scrolling, I've briefly spoken and Dr. Khan's briefly mentioned some of these structures. So in a very similar fashion, we'll do some scrolling as well. If you can write your answers for what you think structure number 1 is.
So answers are coming. You want me to tell you the answers now, or?
Just roughly, yeah, just a rough common answer is good enough.
Internal cerebral vein, I believe, is the most common answer.
Yeah. Important just to make sure is that you always cover a side. You can see that these are paired structures. Very good that you've identified these are internal cerebral veins, but really crucial that you identify, if you can see 2 paired structures, that you do try to identify the right or the left. So the right answer would be the left internal cerebral vein. Okay, number 2. I'll give you a few seconds.
Straight sinus.
Excellent. And number 3.
Superior sagittal sinus.
Excellent. Perfect. All of them are correct. What do you think this structure is?
Still people are thinking posterior cerebral artery, left PCA, basal vein, vein of Lab.
Okay. So slightly so, the vein of Lab, remember it's the superficial vein, so it'd be around the cortex, so you wouldn't necessarily see it centrally. A good thought when it comes to in the context of the posterior cerebral artery, it doesn't really tend to have this trajectory where it converges towards the midline. And especially considering that we're talking about the veins, is more likely the vein that I'm trying to hint out in this one. The posterior cerebral artery tends to diverge and converge at this point over here. This is almost, it's difficult to completely imagine, but it's essentially a structure which is quite prominent centrally, and it would eventually become a bit more narrow. But you can just about see these structures, the third ventricle in the midline slit-like, and you can just about see part of the thalamus over here. So this is actually the basal vein of Rosenthal on the left side.
And by the way, last 2 answers were correct. 2 of them have written that.
Perfect, excellent. And this is why I wanted to mention this one, because I had this in my anatomy exam, where it wasn't really clear exactly where it was coming from, but you've got an appreciation that you're not really expecting to see a big chunky branch of the PCA at this level. It would typically be very small pinpoint vessels. Maybe this is probably one of the PCA branches. So they're very small, narrow caliber vessels by this point. Excellent, good attempt. And as we're scrolling further south, you can just about see this vein. So if you can write answer for what you think this one is.
Vein of Lab.
Excellent. So you can see that there's a horizontal segment. It's not easily seen because sometimes it has this oblique orientation. So as you can see on this side, you can only sometimes see short segments of it because it doesn't have to be in a very straight line. But if you can see a very prominent vein horizontally, and you know you're quite low down because you can just about see the midbrain as well. So use other brain landmarks to orientate yourself, and that will help you answer. But that's excellent. That's the vein of Lab.
So, Saqib, somebody has indirectly, I'm asking the question, cortical vein, will you accept that as an answer?
I think, so again, this was a topic of debate because there are multiple cerebral veins here. And any one of them could be the vein of Lab in theory. But because the only reason I pointed this one out is because it's quite a large caliber in comparison to the rest. The rest of the jaw, and it has a fairly horizontal and continuous trajectory. That's the only reason it's quite confident it's the vein of Lab. The rest of the cortical veins, remember, they either drain directly into the vein of Lab or they drain into the sagittal sinuses. So it's very rare for them to have these horizontal or kind of orientation on a single slice. They'll tend to be end on. So if you see any long horizontal segments of the veins just in the lower part of the calvarium, that's why it's the vein of Lab. The rest of these cerebral veins, they wouldn't really ask you. So I think you can be a bit more specific than cerebral vein in this case. Okay, moving on. So we're going further south. And if you can answer number 1.
Confluence, torcola, confluence of sinuses.
And number 2.
Left transverse.
Perfect. Okay, as we're coming further south, if you can answer number 1 again.
Sigmoid.
Yes, perfect. And number 2.
Internal jugular bulb. Jugular.
Characteristic 3 structures over here where you can see that the jugular bulb, you've got the nerve bundle here and also the internal carotid artery. Hopefully we'll cover this anatomy in a bit more detail when we come to the base of skull over the next coming weeks. Very well done, everyone. So just a couple of more CT venogram images just to orientate yourself with the slightly more unusual presentations. This is a maximum intensity projection image. So there's multiple slices converted into one, and you can see this structure here. What is this structure over here? I haven't labeled it with an arrow, but where my arrow is right now, if you could write your answers in.
Basal vein of Rosenthal.
Excellent. So tricky question, but the important thing is try to find something you can readily identify it, then try working it out. You can see that we are roughly midline. You can just about see part of the ventricle. You can just about see part of the corpus callosum, hopefully. So you know we're in a midline location. You can also see the pituitary as well, which gives it away, and part of the clivus. So these central veins, which almost go quite flushed, quite close to the ventricles themselves, are without a shadow of doubt the internal cerebral veins. And you can see there's one prominent vein which is partially captured, so you know it's converging or verging over to the side, out of view, but it's essentially merging with this, and that's why you can be confident this is the basal vein of Rosenthal. This would essentially go a lot more laterally, and that's why you can't see it. And where they join is that vein of Galen. Just very similar, presenting something similar. So you can see that these internal cerebral veins, you can see the paired structures, the vein of Galen, and then you can see this confluence with the inferior sagittal sinus, and then the straight sinus as well. Very occasionally you have something called the occipital sinus, which comes south just below the the confluence of sinuses. So occasionally that can be asked in questions as well. And finally, again, we probably cover this. It's important to make sure all these venous structures I'm showing you have an appreciation of what they look like in the coronal sections as well. As you know, that the internal cerebral veins go through the floor of the ventricles, quite close to the midline. So these are the paired internal cerebral veins. There's no artery which has this trajectory. There's no artery which will be within the ventricles that is that large or that prominent. So it's important that you make that distinction, that it's a vein and not an artery. Excellent. So we'll move on to fluoroscopy to finish off the venous section. And this can be challenging because most fluoroscopy studies aren't typically done for the veins. And the way it's done is when people are injecting the contrast, they typically wait for about 5 or 10 seconds, and then you can see very good enhancement of the durovenous sinuses and the cortical veins. Again, just for repetition's sake, because we're not really dealing in CT or cross-sectional slices, a lot of these 3D structures will be presented in this 2D plane, which can really be confusing. So it's important to try to pinpoint a familiar structure and work out the rest. If I'm happy that this is the straight sinus, I know that this is the vein of Galen. Centrally and a kind of slightly more horizontal projection, I know this would be the internal cerebral vein. And there's one more structure coming out to the side. It looks like it's going inferior, but in actual fact, it's coming out to the side laterally. But considering the anatomy I know, this is the basal vein of Rosenthal. A few further examples. Again, you can, in this specific example, see part of the sphenoparietal sinus, not easily seen in most fluoroscopy studies, so I wouldn't necessarily focus too much on it. I think you're more likely to receive questions related to these major sinuses and internal cerebral veins. This is just a very quick example of the vein of Trollard. As you saw in that previous CT, so a lot of these superficial veins kind of stopped at this point over here. This vein of Trollard is very prominent and is in continuation with two veins, one that goes anterior, one that goes posterior. And that's why this is quite clearly the vein of Lab, and this is the superficial medial cerebral vein, which essentially does at some point join the sulcus and drains into the clivus plexus or the internal jugular vein. So I'll skip past this one. This is the same structure in AP and lateral views I'll go through. The vein of Trollard is seen as this very prominent vein. Remember, we're kind of completely AP projection now. So all of these superficial veins are merged into one. So you don't really need to focus on all of these. This very large prominent vein is the one to be focused on. It probably at some point joins the vein of Lab, so you can't see it as clearly distinguished. But if you can see a very prominent vascular structure around the calvarium and it's superficial, joining to the venous sinuses, is very likely the vein of Trollard. And I'll go through a couple of angiographic images just so you can see that venous drainage pathway and have a better appreciation of it as well. So this is the internal carotid artery on the left side. And as you can see, some enhancement of the carotid T medially, and you can see a very sharp demarcation, not crossing the midline. So I know for a fact that this is the carotid bifurcation. And as I give it a few seconds, you can see all of these venous pathways lighting up. So posteriorly is the superior sagittal sinus, confluence, transverse sinuses, sigmoid, and internal jugular vein. And then these very large prominent veins over here, which is the vein of Trollard. To go into a lateral projection, again, internal carotid artery angiogram. There's no branching vessels proximally. That's why I'm confident it is. And I can see all of these vessels are converging in all directions rather than posteriorly. So I'm confident that this is an internal carotid angiogram. As I go through that, you can see, again, these veins light up quite nicely. The superior sagittal sinus, straight sinus, transverse sinuses, and then the sigmoid draining into the jugular. And these are hopefully ones that you'll very readily easily identify. These important venous structures over here, you can see that they are plugging directly into the transverse sinus, which gives you the clue that this is the vein of Lab. You can see these and obviously there are, in this specific case, there are two very prominent veins of Trollard on both sides. This is again why it can be slightly confusing, because obviously you have two vascular structures, you can almost assume it's on the same side, but actually it's on both sides. So this is a very prominent large vein of Trollard. Now, in these kind of cases, people have asked me questions about how do you know which one's left or right? If they don't tell you, don't say. For me, without any extra information, I will never know which one's left or right. And by guessing, I risk losing marks. If they, for example, sometimes they have an orientation box at the bottom over here, which tells you which side is the left, which side is the right. In that circumstance, you can make a judgment, perfect. If you cannot, do not mention a side. Okay, so in this case, as you can see over here, we're going through some very similar projections, but this is actually an oblique projection, so slightly different view, just to get your mind around the vascular configuration. So sagittal sinus is coming through with a confluence, straight sinus over here, and then you can see the transverse sinuses coming across on both sides, and then going into the internal jugular. And you can see these large Trollard veins as well. So that concludes the venous anatomy. I think if you've got a bit of time, Dr. Khan, should we reserve the quiz for another time, or?
Yes. So what we are going to do is the quiz we will I think next session or whatever, but we will do it because the quiz from my component is also pending. So we will do it separately.
Sounds good. Perfect.
I
Well, in
think
that case, thank you for listening, and I apologize that I was a bit late, but hopefully you found it useful.
Yeah, so apologies to everybody. Today we ran a bit late. I think what I'll do is that because next session partly base of skull, so we will add anything which we had to rush through today, and we will add quiz also to consolidate everything and take it from there. So we are in the same region. So I don't think so there is going to be much of an issue. So we will cover everything which was left today. Thank you very much, and apologies to everybody who don't understand the BST time change. So remember now there is going to be 1 hour difference. Okay then.